I think next speaker is Dr. Rahul Jain. Yes, Dr. Rahul Jain, we have heard you earlier also, an excellent speaker. Always nice to listen to you, Dr. Rahul. And you will be speaking on peptic ulcer diseases and the importance of adherence in peptic ulcer diseases, long-term therapy in peptic ulcer disease. Over to Dr. Rahul, please. Thank you.
Many thanks to our respected Santanu sir and Prabir sir, and I would also like to thank my dear friend Dr. Shambo, and of course, coming after the excellent speech of Dr. Prateik Poddar, it's a pleasure to be here and speak to all of you today. Now, I am, because I happen to be an internist, I come across people who are suffering from many kinds of diseases of all organ systems. And peptic ulcer disease is something which we see very, very often in our outpatient departments. Can I have the next slide, please? So, peptic ulcer is a defect in the gastric or duodenal wall that extends through the muscularis mucosa into the deeper layers of the wall. And our basic primary target to treat peptic ulcer will be to treat the underlying etiology and eradication of Helicobacter pylori. And we have seen that there is higher healing rates in patients with the duodenal and gastric ulcers with the eradication of H. pylori compared to only using proton pump inhibitor or H2 blocker. Now, the important thing that I would like to would like to emphasize here is that most of the cases of peptic ulcer disease have can be treated simply by using proton pump inhibitors and by eradicating H. pylori. Some of these peptic ulcer diseases can be recalcitrant, and especially persons who are taking long-term drugs such as corticosteroids, people who are taking medications like bisphosphonates, people who are taking painkillers, and various other rare and unusual conditions, they can also have a lot of peptic ulcer disease. So, other than that, remission rates for gastric and duodenal ulcers when H. pylori is treated is 97 and 98%. When you compare and contrast that with only using proton pump inhibitors, in which you will only get a 61 to 65% and 65% healing in gastric and duodenal ulcers, respectively, when only proton pump inhibitors are used. The important thing here is what Dr. Prateik was mentioning was that the average, he mentioned a particular statistic that 14 months was the average duration during which people would take hepatitis B medications. The problem we face as clinicians, as internists, is something of excess. And it's important that everyone should realize that people should de-prescribe NSAIDs when and where possible. And even in the case of peptic ulcer disease, I make a humble appeal to people who are prescribing proton pump inhibitors with at the drop of a hat is to de-prescribe and slowly taper off proton pump inhibitors because they are, one of the most abused drugs. I feel, in fact, the problem we have as internists is the problem of plenty. It's not that people stop. Even when we ask people to stop proton pump inhibitors and not pop them up like a lozenge or a toffee, they keep taking proton pump inhibitors. And the problem which compare and contrasted with the problem of, say, chronic disease like diabetes or high blood pressure or chronic hepatitis B, which cannot be cured but can only be ameliorated by giving chronic therapy. The problem with acid peptic disease, GERD, the problem is that people keep taking these drugs, often to disastrous results in the body. Can I have the next slide, please? So, like I mentioned, non-steroidal, non-NSAID, and non-H. pylori peptic ulcer diseases can be due to other drugs as well, which I had briefly mentioned. Paracetamol is surprisingly a drug which makes it to the list. it's not as innocuous as we think it is, but very, very small percent of patients can have peptic ulcers because of paracetamol as well. Bisphosphonates, steroids, clopidogrel, sirolimus, spironolactone, and the selective serotonin reuptake inhibitors, especially venlafaxine, 5-fluorouracil, then the certain bugs such as Helicobacter heilmannii, herpes simplex virus 1, cytomegalovirus, Epstein-Barr virus, Candida, mucormycosis. Of course, mucormycosis is very much in the vogue now. Then there are certain obstructive congenital duodenal webs, hypertrophic pyloric stenosis, annular pancreas, foreign bodies, especially in people with psychiatric disturbances, trichotillomania, we call them trichobezoars, can be seen. We've seen a couple of cases of trichobezoars in endoscopy. Recently, we've also seen very frequently in our hospital, we do a lot of gastric bypass surgeries in the hospital I practice in. So peptic ulcers are common there as well, ruined by gastric bypass. Even mini gastric bypass can present with peptic ulcer disease. Gastrinomas, Zollinger-Ellison syndrome, mastocytosis, myeloproliferative disease. I must confess I don't come across these cases too much. Then there are cases like sarcoidosis, Crohn's, IgG4 disease, Wegener's, and stress ulcers in the ICU. Stress ulcer bleeding is something we see a lot, especially after head injury, after massive intraventricular hemorrhages. We see a lot of patients who present on the third, fourth, fifth day with hematomesis and melena. And when we scope them, we see that there is stress ulcers in the stomach or duodenum. So we do get these cases, and of course, why forget the long-term use of proton pump inhibitors, which causes a hypersecretory duodenal ulcer. And I suspect we are going to see more and more of these cases as the lowly, PAN 40 or Omes becomes it's already a over-the-counter medication. As more and more of these drugs are overused and misused, we are going to get more and more of these cases. Can I have the next slide, please? So, first line therapies for H. pylori, there are a number of different protocols. Bismuth quadruple, we don't use bismuth here at all, but what we do use in peptic ulcer disease is the standard proton pump inhibitor, whether it's a lansoprazole or a pantoprazole or an omeprazole, with a clarithromycin and amoxicillin. Clarithromycin in the dose of 500 twice a day for 14 days, and amoxicillin twice daily for 14 days, concomitant with clarithromycin and PPI double dose. And if the person does not tolerate amoxicillin, then we give metronidazole thrice a day along with clarithromycin and PPI for 14 days. So this is the basic triple therapy, which is used very, very frequently. At least I use a lot, and to good results. The next slide, please. So, as we know, the actions of anti-ulcer medications, we have the surface-acting antacids, we have the H2 receptor blockers, where the H2 blockers work, and of course the hydrogen potassium ATPase pump, where the proton pump inhibitors work. And these are the basic sites where these drugs are being used. Antacids are also available over the counter. And I'm afraid a lot of people, especially in our culinary, who indulge in a lot of culinary adventures, they often pop in, they keep on the bedside. I've seen many people who keep these bottles of Digene and Gelusil, and they always have antacids readily available at hand, and are taking in small aliquots of antacids, surface-acting antacids, whenever they require. So I was mentioning the problem here is the problem of plenty. So where do we draw a line? The problem with the compliance is the over compliance, should I say, or even when it's a particular medicine is deprescribed, people continue it, and often to disastrous effects, which I will come to in my next few slides. But people who do not take, for example, people who have proton pump inhibitors and don't take, for example, the H. pylori medication because of cost, clarithromycin being an expensive medicine, metronidazole or tinidazole can have awfully bad metallic taste, and of course amoxicillin can present with the diarrhea. So because of cost and diarrhea and because of bad taste, some people can, there will be a group of people who will not take these medications, and they can end up with all sorts of problems such as duodenal strictures and perforations, hematemesis, melena, and of course we have the plain variety of patients who are presenting to us simply with chronic anemia, unexplained anemia, or heartburn. Some people are presenting with dyspepsia. So, in addition to the loss of the quality of life, people are also presenting with. In the case of people who are not adhering to the or not complying with the prescription of the triple therapy or the quadruple therapy of pantoprazole with or a lansoprazole or an omeprazole with a clarithromycin and amoxicillin or metronidazole. So, and then I talked about the long-term abuse. I prefer to use the word abuse of proton pump inhibitors, which is a pandemic. It's almost worse than COVID in our country. Next slide, please. The problem is that these drugs are have a primary and a secondary pathway, and a number of cytochrome enzymes are involved in the hepatic metabolism of these particular drugs, and they are supposed to be taken in a for a limited amount of time for a specific reason. And the moment any of these drugs are popped in like a Poppins or a toffee, then we have the problem, because long-term intake of these drugs can lead to a lot of deleterious side effects and drug interactions, which can very adversely impact people. A number of reasons why people I have a lot of patients who have diabetes, they have high cholesterol, they have blood pressure. Some have all three, and some people have various combinations of, three anti-hyperglycemics, one anti-hypertensive or two anti-hypertensives, one dyslipidemic, one pantoprazole, and all sorts of medications are going on. And many a time they come back, and I've seen more often than not, they'll stop their cholesterol medication or they'll stop their blood pressure medication, but they continue to take that pantoprazole and that omeprazole. I don't know how common this is with my esteemed speakers in this co-panel, but I find that exceedingly common that people will stop medications, will go for all sorts of herbal and alternative therapies, but will continue to take the PPI. It's something which baffles me as a physician. What is it which is so addicting about these proton pump inhibitors that people keep taking perennially for weeks, months, years, and even decades? I suppose it gives a lot of people confidence to take alcohol whenever they want to eat rich food, biryani at the drop of a hat, and not feel the um pangs of eating such a rich food. People can eat at all odd hours. There are students, there are doctors I know who are completely addicted to drugs like pantoprazole and omeprazole because of our irregular eating habits. And that leads to a lot of problems. Can I have the next slide, please? So I was talking about some of the drug interactions which happen with the proton pump inhibitors. Warfarin is a drug which has an interaction with commonly used PPIs. Diazepam is another drug in which the T half is increased very significantly because of decreased clearance. Phenytoin can have an increased T half, and phenytoin, as you know, is a toxic drug if it goes beyond the therapeutic window. Theophylline is another drug in which the area under the curve is increased by 10%. Digoxin. Now, these are very toxic drugs, and there's a specific dose in which they are given, and if they either exceed that or fall below the margin, then they're not supposed to be doing what they should be doing. Then they cause more adverse reactions than to help ameliorate the condition for which they were initially prescribed. Again, carbamazepine is a drug which has interaction with a lot of these proton pump inhibitors, specifically omeprazole. And over here, I would say pantoprazole is a drug which perhaps scores better than the other drugs. Can I have the next slide, please? Okay, we'll let this slide pass. It's very, very small. You'll not be able to read. So, adverse effects of long-term PPIs. We see a lot of adverse effects of long-term PPIs. Now, we are seeing more and more cases of C. difficile infection in the hospital. And one thing which I found common with, other than antibiotic-associated diarrhea, is long-term hospitalization and many antibiotic therapies given to patients. Is one thing which I've seen is the long-term use of proton pump inhibitors. So Clostridium infection is purportedly more with the long-term use of PPIs, and Salmonella and Campylobacter we have classically seen in that typhoid is a drug. Typhoid is a disease which happens when there is in excess when there is achlorhydria or hypochlorhydria. Microscopic colitis, hypergastronemia, which I talked about because of the excess duration of long-term use of, or should I say, long-term abuse of proton pump inhibitors is these are big compliance issues. Chronic atrophic gastritis, intestinal colonization of multi-drug resistant organisms. That's not a very uh, pleasant thing to happen, because you're inviting all kinds of bugs in your body because of the protective loss of the acid secretion in the stomach, and growth of microbes which produce extended spectrum beta lactamases, ESBLs, carbapenemases, or plasmid mediated AMP-C beta lactamases, vancomycin resistant enterococci. So these are again these are dangerous things to have, especially in the hospital setting. One you might come across. In fact, I've come across people who get urinary tract infections, chest infections in the community. They come with all sorts of resistant bugs. One of the problems is the easy availability of antibiotics over the counter. Go to any chemist shop, and you will find that you can easily avail of these antibiotics, 2 tablets, 3 tablets, 4 tablets, whatever you want you can buy. You don't need to buy strips. And the other is, of course, I strongly suspect that long-term use of PPIs have a role to play in this. We also see very, increasingly it's become common that magnesium malabsorption. I've seen, we routinely measure now, whenever a patient walks into the hospital, we are routinely measuring magnesium. The other epidemic, which is, sort of running parallelly with PPI abuse, is that of the COVID, where people are, just popping zinc like it's nobody's business. And PPI and zinc, it's a deadly combination. Most patients who are coming in with the magnesium levels of 1.3, 1.2, 1.4. That's very dangerous. Lack of calcium absorption, which is going to lead to, fractures and weak bones, osteomalacia, depending on what age the patient is in. Vitamin B12 malabsorption, iron malabsorption. Now, all these things are adverse effects of long-term PPIs, which we despite being de-prescribed or prescribed for a small period of time, people continue to take, and these are not very great things to happen. The other problem that I find with the use of proton pump inhibitors is that the friendly doctor, instead of giving a simple single drug like pantoprazole or esomeprazole, adds the deadly duo of you have all these drugs which end with either D or L. That's a disaster, because I have seen in my practice, I have seen approximately 10 patients with permanent extrapyramidal symptoms. There was this elderly lady. She used to come to me for, amar gas hocche, amar, and she refused to do an endoscopy. She would simply refuse to do an endoscopy. I kept telling her that I think you have peptic ulcer disease, you have symptoms, some symptoms of gastroesophageal reflux. Please do a endoscopy. She refused to, and she went to her, neighborhood doctor, who prescribed her a particular brand of pantoprazole and levosulpiride combination. Now this is a drug which really scares me. I don't know what the view of my co speakers is. She took it in a twice daily dose for 6 months, and guess what? She comes to my chamber, this elderly, well-behaved lady, Muslim lady wearing a burqa, and she opens her, sort of head covering, and she's winking. It's very very embarrassing. I said, what happened to you? He said, Ami Janina, and it's this kind of facial, tardive dyskinesias, orofacial dyskinesias. People come with frank Parkinson's disease after the intake of levosulpiride. Even domperidone, purportedly some domperidone finds its way across the blood-brain barrier and can predispose to extrapyramidal syndromes, extrapyramidal side effects. So these are, any drug is unless it's given for a rational indication, these are issues, and people don't stop taking them. What Dr. Prateik, the problem he faced, I faced the opposite problem. These are compliance issues. These are, integral issues that we as physicians have to realize when to stop and to communicate. I liked how Dr. Prateik Poddar stressed on the fact that communicate, counsel, communicate, counsel. I like that approach, because no matter how much we communicate and how much we counsel, it is up to the patients to understand and take drugs which are prescribed to them, and to stop when they are asked to stop. Can I have the next slide, please? So there is a lot of, I put a lot of question marks here. Kidney disease is something which can happen with long-term use of proton pump inhibitors. Some of that may be due to secondary magnesium deficiency. Drug-induced lupus is being talked about with the long-term use of PPIs. There have been some reports, unsubstantiated, unverified in big studies about increased risk of COVID-19 infections. There are also studies which talk about increased risk of dementia, of different kinds of pneumonia, and increased all-cause mortality with the long-term use of proton pump inhibitors. The next slide, please. So we talked about how the proton pump inhibitors, which are the mainstays of treatment of peptic ulcer disease, are metabolized by the hepatic cytochrome P450 enzymes. It's EYP2C19 having the dominant role. So some people can have these gene mutations, which can have, and they can have higher plasma PPI levels in homozygous individuals, and can become a major target for interaction with many drugs, including warfarin, diazepam, clopidogrel, and phenytoin. And there is decreased activation of clopidogrel when used in conjunction with omeprazole due to shared hepatic cytochrome P450 mediated metabolism. Some HIV protease inhibitors are contraindicated with PPI, such as rilpivirine. Atazanavir should not be used in patients who are requiring a dose more than 20 milligram or equivalent of omeprazole daily. And methotrexate is another. You have to, we don't have the means and whereabouts to monitor methotrexate levels readily available in our country. And co-administration of PPIs with high-dose methotrexate appears to be related to higher levels of methotrexate in the blood, and potentially may lead to liver damage, bone marrow suppression, infections, and what have you. I have seen many patients of who are receiving methotrexate, for example, for psoriasis or for different kinds of other, illnesses in which they come in with the total white cell counts of 400, 500, 10%, 5% neutrophils. Needless to say, a high percentage, very high percentage of these patients end up losing their lives, or they come with irreversible liver damage. Now, obviously, we don't have gene studies whereby we can, quantify how much. And guess what? Most patients who are on any long-term, especially painkiller medications, are almost always. If I think our senior teachers like Prabir sir and Santanu sir can do studies about the co-prescription, or should I say, the irrational co-prescription of and continued abuse of PPIs, which I cannot overemphasize in the time which has been given to me. And perhaps we can get more data on the same. The next slide, please. Okay, I think that brings me to the end of my talk. And I would love to face questions at the end of the program. Thank you very much.